Okay, good afternoon. First, I must thank the Ceylon College of Physicians for giving me this opportunity. I'm Sanjeewa Malinda, Senior Registrar in Respiratory Medicine from National Hospital for Respiratory Diseases, Sri Lanka. So, today I'm going to talk about interstitial lung diseases in connective tissue diseases. So, I have divided my talk into three parts. In the first part, I'm going to introduce you to the interstitial lung disease or diffuse parenchymal lung disease, which we call the ILD, and then how we manage ILDs and ILD classification, and a little bit about idiopathic pulmonary fibrosis, and then I'm going to talk about specific connective tissue diseases related ILDs. At the latter part, I'm going to talk about management of connective tissue disease related ILDs and place for antifibrotics in ILDs. So I'm trying to keep this talk as simple as possible. So what are the connective tissues? Connective tissues are the tissues which maintains the form in our body and keep the organs in their places, which contains a lot of various types of cells, fibers in a matrix. So the connective tissue of concern to this particular lecture is the lung interstitial connective tissue, which lies between the alveolar epithelium and the vascular endothelium, which is responsible for gas transfer. So there are over 200 interstitial lung diseases in the world. So we have classified into certain groups. So I'll slowly take you through this classification because it is very important to have an idea about this classification in order to understand interstitial lung diseases. So interstitial lung diseases, so diffuse parenchymal lung diseases, we mainly divide into four categories. First one is interstitial lung disease with the cause. Second one is interstitial lung disease, which we can't identify a cause, which we call idiopathic interstitial pneumonia. And then the granulomatous interstitial lung diseases, then we divide into other forms of interstitial lung disease. From that, idiopathic interstitial pneumonias, we again divide into three parts. That is chronic fibrosing interstitial lung disease, acute and subacute fibrosing interstitial lung disease, and smoking-related lung diseases. So first, on the chronic fibrosing interstitial lung disease, we again divide into idiopathic pulmonary fibrosis, which is the most common worldwide, and idiopathic non-specific interstitial pneumonia. And acute and subacute fibrosing interstitial lung disease, we have cryptogenic organizing pneumonia, or the organizing pneumonia as we call it, and acute interstitial pneumonia, or AIP. And smoking-related ones are respiratory bronchiolitis interstitial lung disease and discomitative interstitial pneumonia. So it's a little confusing when you hear these names. Everywhere is pneumonia. So what is pneumonia? So pneumonia is defined as an infection leading to inflammation of the lung tissue, and that inflammation causes tissue edema, collection and recruitment of inflammatory cells and inflammatory mediators, and leading to problems. So not only infections, this inflammation can occur as a result of other insults such as autoantibodies, organic or inorganic dust, smoke, various fumes and gases. So how does this inflammation heal? So we have the injury due to various causes like chemotherapy, autoimmunity, radiation, environmental particles, drugs, etc. And we have the inflammation. Then when we heal, the debris get reabsorbed, and sometimes as a result of repair, the fibrin laying occurs. So when there's dysregulation between this healing process, in this healing process, you get excessive fibrin formation leading to lung fibrosis. So these changes which undergo inside the lung is evident by clinical features, and we can take a peek into the lung by means of doing HRCTs radiologically, and by doing biopsies we can do the histological, we can see the histological appearance. So you can see the normal lung, and it, after subjecting into various insults, it undergoes inflammation, which evident as ground glass appearance in the high resolution CT, maybe consolidation as well. So when it goes further, we get the dysregulation of healing process, and you get more fibrosis, which is evident as a fibrotic pattern, the reticulation, nodulation, and honeycombing. So the process I just told you, which is undergoing inside the lung, is evident by other various patterns in the HRCT as well. You have the normal parenchyma, you have the ground glass, like I just mentioned, and there can be reticular banding, nodules, and linear scarring, subpleural banding, and paraseptal emphysema, and centrilobular emphysema. So, the radiological diagnosis of interstitial lung disease is done by looking at these changes as well as looking at the distribution of these specific changes throughout the lung parenchyma. As an example, non-specific interstitial pneumonia, if there's ground glass opacities in bilateral symmetrical distribution with basal involvement and subpleural distribution with immediate subpleural sparing, we call it non-specific interstitial pneumonia radiologically. And in usual interstitial pneumonia, we get honeycombing, reticular opacities, immediate subpleural and basal involvement, and craniocaudal pressure distribution, and there can be traction bronchiectasis and volume reduction, and we call it UIP pattern. So is the radiological diagnosis enough? No. We have to conduct a multidisciplinary team meeting with the involvement of the pulmonologist, the radiologist, and the rheumatologist in the connective tissue disease related ILDs, and if you have done a biopsy, the pathologist. So we all get together and discuss regarding the clinical features, the radiological appearances, the serology, autoimmune profile, and the other rheumatological clinical manifestations, and if you have done the biopsy, the histological appearance, and we arrive at a consensus diagnosis. So after the diagnosis, there are a few questions we answer. Whether to start immunomodulators. If you are starting immunomodulators, which agent to start? Need induction first, like with methylprednisolone pulsing or cyclophosphamide pulsing, and whether to start single agent or start two agents at the same time. And whether to start antifibrotic agents, whether to start both antifibrotics and immunomodulators at the same time, and when to reevaluate. So in the reevaluation, we do the clinical evaluation to see if the patient is improving or deteriorating, like using MMRC-like scores. And we look for drug side effects, and we look for infections because we are giving immunosuppressants. And we do the functional assessment by 6-minute walk test, and we do the disease evaluation by repeating the HRCT and lung functions, including carbon monoxide diffusion capacity, and sometimes ABG as well. And we screen for other organ involvement because connective tissue diseases are multi-organ involvement diseases. And we evaluate for complications such as pulmonary hypertension, and we revisit the diagnosis, whether we have done the correct diagnosis, and we manage the side effects and complications. And we decide whether to intensify, tail off, or continue the same management. So this is a cycle which goes on until we are following up the patient. We do the MDM, we do a diagnosis, we lay out the management plan, and we monitor the patient, and we do the re-evaluation, and we again do the multidisciplinary team meeting and decide on further management. So I'm coming to the part 2 of my lectures, where I'm going to talk about a little bit of about IPF, idiopathic pulmonary fibrosis, and connective tissue disease associated ILDs. What is IPF, or idiopathic pulmonary fibrosis? In our classification, it comes as idiopathic interstitial pneumonia, chronic fibrosis type. So this is the commonest interstitial lung disease worldwide, but in India, hypersensitivity is more common. We don't have our own ILD registries in Sri Lanka yet, but we believe it behaves same as India. So why we talk about IPF? Idiopathic pulmonary fibrosis is a progressive, life-threatening interstitial lung disease of unknown etiology, and the median survival of patients with IPF is only few years. Respiratory failure resulting from disease progression is the most frequent cause of death, and 5-year survival is about 45. So it is less than most of the cancers we know. So if we diagnose idiopathic pulmonary fibrosis, we have to do the breaking bad news and lay out the management plan, including the end-of-life care. So, diffuse parenchymal lung disease. Having said about the idiopathic pulmonary fibrosis, Now I'm going to talk about connective tissue disease associated interstitial lung diseases that comes under interstitial lung disease of non-cause. So here the cause is connective tissue disease. So like I said, idiopathic pulmonary fibrosis or the IPF carries a poorer prognosis. But when we compare prognosis of connective tissue disease related interstitial lung disease, they have better prognosis. So it is important to know when there's an ILD with the connective tissue disease, they have a better prognosis than the idiopathic pulmonary fibrosis. At the same time, you should also know that if there's a connective tissue disease and the same patient has ILD, they have a poorer prognosis than those who have only the connective tissue disease, right? Okay. So here I'd like to introduce another term which we call Ipefo, or interstitial pneumonia with autoimmune features. So CTD ILD means there's a interstitial lung disease with a connective tissue disease which fulfill the criteria to the particular connective tissue disease. But in reality, it's not always, it's like that. So then we have the entity called interstitial pneumonia with autoimmune features. So we have the ILD, there are autoimmune features, but that does not fulfill the criteria to a definite connective tissue disease. At the same time, that ILD is not explained by other things like exposures. So how to diagnose IPF or interstitial pneumonia with autoimmune features? So we have clinical domain, serological domain, and morphological domain. You have to have at least one from two of the three domains which are mentioned here. Right. So this is a very important slide. I'd like to spend a couple of minutes on this slide. This shows the prevalence of connective tissue diseases in the society. And it also shows prevalence of ILD in that particular connective tissue diseases. As an example, you can see here the rheumatoid arthritis is the most common connective tissue disease in the society, which accounts for like 0.25 to 1% in the society. But prevalence of ILD among those patients are little less. In contrast, you have systemic sclerosis, about 13 to 25 per 100,000 are in the society, and there's about 50% patients with interstitial lung disease in systemic sclerosis patients. But since there are a lot of rheumatoid arthritis patients in the society, we see a lot of rheumatoid arthritis associated interstitial lung diseases. So it's like that. And this chart also mentions the dominant HRCT pattern in each connective tissue disease. As an example, rheumatoid arthritis have UIP pattern in the high resolution CT, and all the other connective tissue diseases usually has more NSIP pattern. And it also shows which interstitial lung diseases in the connective tissue disease are progressive. So systemic sclerosis associated interstitial lung disease, myositis associated interstitial lung disease, and rheumatoid arthritis associated interstitial lung disease are progressive. So are we going to treat everyone? No. We are treating those who have significant disease. So what is meant by significant disease is if the patient has baseline carbon monoxide diffusion capacity less than 50%, we take it as unequivocally significant. And if VC is lower than the lower limit, and if the patient is symptomatic, we take it as significant disease. And there are markers of progression. More than 10% FVC reduction, forced vital capacity reduction, no more than 15% carbon monoxide diffusion capacity reduction, we take it as progressive disease. This is another thing. This ILD could precede the connective tissue disease. So in some patients, ILD could be the first presentation. We call it lung dominant connective tissue disease. And sometimes it could be an evolving connective tissue disease with features of interstitial lung disease, like interstitial pneumonia with autoimmune features. Later on, the diagnosis might change. And sometimes the autoantibodies can be the only positive thing for towards connective tissue diseases. So therefore, we should actively look for connective tissue diseases. We are actually actively looking for connective tissue diseases in all the ILD patients we get. And the rheumatological clinic also should actively look for interstitial lung disease in their patients. And having said that, actually, in every clinic, in any clinic, if the patient has features of connective tissue disease, they should look for ILD features. If they have ILD features, they should look for connective tissue disease features. So these are some of the connective tissue disease features we encountered in our respiratory clinic. So you can see dactylitis, nail fold capillary dilatation, fingertip ulceration and mechanics hands, and poikiloderma, got transpapules, and photosensitive rashes, speckled leukoderma, vasculitic rashes, heliotrope rash, mechanics hands, like that. And Raynaud's phenomena, usually it's like sort of difficult to see Raynaud's phenomena in our patients due to dark skin, but now they have smartphones and they take photos and bring us. So vasculitic rashes, skin thickening, got transpapules again, like that. So we should carefully look for those signs in our patient. So now I'm going to talk about systemic sclerosis related interstitial lung disease. So another important thing is limited cutaneous systemic sclerosis patients have more pulmonary hypertension than fibrosis, and diffuse systemic sclerosis patients have more fibrosis than pulmonary hypertension. And interstitial lung disease and the pulmonary hypertension is the commonest cause of death in systemic sclerosis. And in autopsy findings, there are about 70% in lung involvement. That means there are a lot of patients who have subclinical interstitial lung disease in systemic sclerosis patients. Only about 30% have clinically significant disease. Treatment-wise, cyclophosphamide remains the cornerstone of treatment according to Scleroderma Lung Study 1, a multicenter double-blinded randomized controlled trial. And mycophenolate mofetil has also shown similar efficacy with lesser side effects than cyclophosphamide. That is according to Scleroderma Lung Study 2, again a multicenter double-blinded randomized controlled trial. And azathioprine is an alternative to MMF at the expense of more side effects than MMF and less efficacy than cyclophosphamide. Rituximab is an alternative to cyclophosphamide with similar efficacy, again both interstitial lung disease and other skin manifestation of the systemic sclerosis. Then we are going to talk about inflammatory myopathy associated interstitial lung diseases. So dermatomyositis, polymyositis patients have around 50% lung involvement, and antisynthetase system has around 85% lung involvement, and hemoptic dermatomyositis almost 100% lung involvement. I would like to talk a little bit about hemoptic dermatomyositis because during my training, about 2 years, we came across about 4 patients whom we lost 2 patients. Almost all of them were young patients, and they have anti-MDA antibodies positive and rapidly progressive ILD, and they have skin changes, very subtle skin changes and vasculopathies. And in the HRCT and lung biopsy, they have the diffuse alveolar damage or acute interstitial pneumonia pattern leading to ARDS, and which carries a very high mortality. So these were the changes we had in our patients. You can see the Gottron papules are not very prominent. If you are not looking at it very carefully, you won't be able to identify it. And nail fold capillary dilatation, the V-neck sign, and the photosensitive rash. And inflammatory myopathies, like I said, the most common thing is AIP pattern, but NSIP, OP also patterns are also found in inflammatory myopathies. AIP has rapid progression and develop ARDS and respiratory failure, and they should be treated aggressively with methylprednisolone pulsing or concurrent or immediately subsequent cyclophosphamide pulsing, and calcineurin inhibitors, rituximab if not responding, and tofacitinib and IV immunoglobulin. And it's worth to note that organizing pneumonia and NSIP patterns in inflammatory myopathies have a better prognosis. Now I'm going to talk about rheumatoid arthritis ILD, which we call as RAILD. The most common lung manifestation of rheumatoid arthritis is ILD. HRC abnormality is seen in 60%, but only about 10% are clinically significant. And ILD may precede the joint symptoms, and ILD has association with levels of citrullinated peptides. And mortality is 3 times higher in rheumatoid arthritis if they have the interstitial lung disease. And it is a challenging entity because disease-modifying antirheumatic drugs and sometimes biologics also have pneumotoxic effects. So we should be able to differentiate whether if the ILD is due to the disease or the treatment. So in rheumatoid arthritis, in rheumatoid arthritis, the most common HRCT pattern is UIP. And on differentiating from RAILD from drug-induced ILD, I have mentioned here about 2 commonly used drugs, methotrexate and leflunomide. From the disease cause, RAILD has a chronic cause, and methotrexate-induced pneumonitis has acute or subacute cause. Usually they present within one year of starting treatment. And leflunomide has a more acute presents within 3 months after presentation. And the pattern is RAILD, like I said, it's UIP pattern in the HRCT, methotrexate-induced pneumonitis, usually in SIP, and leflunomide, they have AIP pattern, diffuse cellular damage pattern. And distribution also, there are differences. So we have to give a positive diagnosis whether this is due to the disease or whether this is due to the drug. So because it is not wise to unnecessarily withhold methotrexate because it's a cheap and fairly well-known drug. And further about rheumatoid arthritis associated ILD treatment, corticosteroids are the first choice of treatment, and steroid sparing agents are MMF and azathioprine, and cyclophosphamide are also effective. Nowadays, rituximab has also been given with promising results, and infliximab, etanercept, and tocilizumab also have shown favorable outcomes. So general management of connective tissue disease associated ILDs, we have to decide whom to treat, what agent to give, when to start, when to step up, when to step down, when to stop, when to change, when to introduce antifibrotics. So best to be managed by a specialized multidisciplinary team. So approach to management, the aims of management are we have to stop disease progression, reverse the lung damage, which may not be possible always, and prevent disease complications, and prevent and minimize disability, prevent drug complications, and start pulmonary rehabilitation early, and manage symptoms, and manage and prevent exacerbations, and manage complications such as pulmonary hypertension, copulmonale, and respiratory failure, and manage other associated conditions which have been shown to contribute to the mortality of interstitial lung disease, such as gastroesophageal reflux disease and obstructive sleep apnea, and we have to manage other comorbidities as well. So what is the place for antifibrotics in CTD ILDs? Like I initially said, ILD is a progressive disease. So you start from inflammation and end up in fibrosis most of the time. So the trend of the HRCT is very important. And inflammatory changes are reversible while fibrotic changes are not so reversible. And a cross-section will only show the current status of the disease, but not the disease entity itself. You have to identify the trend to comment on the disease. And inflammation progress and eventually end up in UIP pattern, which is a fibrotic pattern. So when to introduce antifibrotics and when to stop immunomodulators is a decision of the multidisciplinary team. In any ILD, not only CTD ILD, there's a subset of patients who will progress to fibrose despite immunomodulation. So those patients we call progressive fibrosing ILDs. So those patients are in the CTD group as well and other ILDs as well. So we call it progressive fibrotic phenotype. So randomized control evidence from the landmark trials on antifibrotics on idiopathic pulmonary fibrosis, or the IPF, gave us an idea whether this antifibrotics could be used in those subset of patients who progress to fibrose. So these two are the landmark trials I was talking about. Ascent perfendone trial, which showed to reduction of FVC decline, and impulses, and Interanib reduced the worsening of FVC. So these trials show when pirfenidone in hemoptic dermatomyositis showed FVC reduction, and pirfenidone in progressive non-IPF lung fibrosis, it also showed reduction in forced vital capacity reduction. So nintedanib also showed reduction in FVC decline, and nintedanib also showed reduction in FVC decline in progressive fibrosis ILD as well. So this is the trial I was talking about. This is the Sensis trial. You can see the nintedanib has reduced decline in forced vital capacity. This is the other trial. Inbuilt trial, it also showed reduction in decline of forced vital capacity. So in summary, we talked about how interstitial lung disease occurs due to dysregulation between injury, inflammation, and repair in the lung interstitium. And diagnosis and management need multidisciplinary team approach, which with ongoing multidisciplinary team meetings to manage the disease. And IPF is the commonest interstitial lung disease worldwide. And we talked about systemic sclerosis associated ILD, rheumatoid arthritis associated ILD, dermatomyositis, polymyositis associated ILD, and progressive fibrosing interstitial lung disease. And we talked about general management of connective tissue disease associated ILDs and place for antifibrotics in connective tissue disease associated ILD. So these are my references. I'm happy to answer any questions.
Thank you, Sanjeewa, for that comprehensive lecture. So anyone in the audience would like to ask questions? So you are here. Anything you answer? Your training. Right. There's an online question. What is the commonest lung involvement in rheumatoid arthritis? Is it pleural involvement or interstitial lung disease?
It is the interstitial lung disease involvement, because symptomatically the pleuritis may be common, but when you take the HRCT evidence, it shows about more than 50% patients have interstitial involvement. They may not be symptomatic, but the involvement is there. So it is interstitial lung disease.
Yeah. And I would like to ask a very general question, right? Everybody knows that the connective tissue disorders are common in females. But when you are listing the risk of interstitial lung disease, most of the things that you said, the male sex has a risk factor. Is there any particular reason for it?
Not that anything that I came across, but anyway, the connective tissue disease in males have a worse prognosis. And maybe same thing applied to interstitial lung disease as well. Nothing that I came across.
Right. Yes. Give the mic to you.
Thank you, Malinda. Excellent talk. I think it's a common question you will come across when a patient is referred to when somebody sees ILD in a CTD patient. Maybe commonly in rheumatoid arthritis patients. And if you have noticed ILD on a patient who have been on methotrexate, what should be your approach as an advice to the audience?
If you come across ILD patient in the rheumatology clinic, yes, I think, like I said, the interstitial lung disease is a complex entity. It's same in everywhere. It's same everywhere in the world. So it is best managed by a multidisciplinary team with the involvement of the pulmonologist, the rheumatologist, radiologist, pathologist, and if there's a expert or pulmonologist with more experience in managing ILD, those teams should get together and manage the patient. So it's those centers who manage in such a way has very good survival. So it's best to refer to a such center for further management.
Yeah. Thank you, Sanjeewa. Now, I think we need to conclude the Young Physicians Forum. On behalf of the Ceylon College of Physicians, I would like to hand over the certificates of appreciation. May I invite Dr. Sunanthan Nirupan to As we have come to the end of the Young Physicians Forum for this year, it's my duty to acknowledge few people. And it's primarily it's you. You are the coordinator of the Young Physician Forum for this 2021, and you have done a wonderful lecture. So wonderful the organizing and the coordination of this. It's a very difficult task. I have done this for last 2 years. It's a very difficult task to find the candidates and coordinating this. So on behalf of the Ceylon College of Physicians, I would like to thank Priyamali Jayasekara, the coordinator of the Young Physicians Forum. And also, I would like to thank the CIPLA. CIPLA is the main sponsor for the consecutive last 5 years and for the year 2021 as well. And also the audiovisual team and everybody who has contributed for the Young Physicians Forum. And probably the next Young Physician Forum will be in January, and you can meet with them at the new council as well.